Lets me know there. Okay, it appears to be recording. So let's begin by clarifying any questions that any of the sites have about what we've already covered up to this point. Well, that's either a good thing, that means you understood it all, or that's a bad thing, meaning that I've confused you so much you don't have a question. Oh, I see a question in Thought. Oh, I can't hear you though, Teresa. I don't have a microphone. You don't have a microphone turned on. Now try.
All right. With particular salt, is that the reason why where salt goes, water follows? With the balance between the two?
I'm not 100% sure I understood the question. It was kind of distorted. Try it again for me.
All right. Is that the reason why where salt goes, water follows? Because of the balance between the two?
Yes. Remember, diffusion and osmosis, they occur continuously. It's not after the problem occurs, then, oh, we better get busy and fix things. It's a continuous balancing act. So when an electrolyte or the cations move across from one fluid compartment to the next, water follows, and vice versa. It's a continuous process. It's not after the problem exists. Okay? It's trying to always prevent the problem. And remember, fluid and electrolytes both only move one compartment at a time, meaning that what's in the interstitial space can go to the cells, or it can go to the vascular space, but what's in the vascular space cannot bypass the interstitial space to get to the cells. It has to first has to diffuse into the interstitial space and then go into the intracellular space, and vice versa. That's real important that you understand that that's a two-step process, and it's not that we jump from wherever we want to go to the next. It doesn't have a, whatever that thing Star Trek used to have, transporter device, okay? Other questions? Okay, then we're going to start at the page of top of 255. I believe we had finished discussing hypovolemia and hypervolemia. And remember, there are some tables in your chapters, in your assigned readings, that address the same things that I discussed as far as nursing actions. And likewise, the two other problems we're going to look at today, hypokalemia and hyperkalemia, the same thing. There are tables on page 1322 that address some of those, address those two problems as well. So I'm going to switch over to our computer now. Hopefully we don't lose anything. And we did. All right, give me a second. Sorry, distant sites.
Yeah, she's here, but she stepped out.
Okay, I think we can go forward. I will do my best not to touch any buttons, and we will go from there. Which, by the way, I have to do a little commercial here real quick. I do not know exactly when the student surveys are sent out as far as classroom and clinical. I know that they're typically sent out during the month of November, but I don't remember how close it is to the end of the month. I have an honest and simple request. Do not evaluate any of the three of us on ITV based on the ITV problems. Those are outside our control. It's not Mrs. Haig, it's not Mrs. Martinez, and it's not me, Mr. Baird, creating these issues. These are technology issues that we have no control over, and so please, sometimes students in the past have raked us over the coals over ITV on our faculty evals, and that's not really fair because it's not something within our power. There is a part when you evaluate the total program. It's a whole separate survey that you get. That's where you comment on ITV, okay? It's talking about the program as a whole. So if ITV frustrates you, make it known in that survey so that administration knows that we have to get these issues fixed for you guys, okay? All right, because we are on the same team. And right now we're on the fluid electrolyte team. Which, by the way, if any of you heard about my friend who usually comes each fall, I apologize, but based on some changes that were made, he didn't get to come today. So I apologize ahead of time, but Flex McComb didn't get to come today. Perhaps you'll see him or hear about him somewhere else at some point in time. All right, so let's talk about hypokalemia. So hypokalemia is very simply, by definition, a serum potassium level less than 3.5 milliequivalents per liter. Remember we said milliequivalents per liter is the primary way we measure electrolytes in the bloodstream, or milliequivalents per deciliter. Okay, so anything less than 3.5 qualifies as a low blood potassium. So what are some etiologies? Well, just like we talked about the other day, everything dealing with fluid electrolytes falls under two broad categories: abnormal intake or abnormal losses. And so when we look at potassium, it's no different. Abnormal intake means that they simply are not eating. Potassium is readily available in most of the things that we eat here in America. Almost every food and almost every liquid that you drink, with the exception of just bottled water or perhaps coffee, those kinds of things, have some level of potassium in them. It's easy to maintain our potassium if everything works right. But when we're not eating, we don't get it. And our body doesn't store it in surplus amounts. It is something you have to consume every day. It's one of those essential minerals that Mrs. Haig talked about. And 80% of what you consume every day is excreted in your kidneys. So you're only retaining a portion of it, but you have to have it. So if you don't have it coming in, your potassium will begin to drop. Abnormal losses are vomiting and diarrhea. Vomiting, again, if you're putting stuff in there, but it's not staying long enough to get into your small intestine to be absorbed in the bloodstream, it never gets to where it needs to be. And so it's like putting something, it's like your kids putting their toys away and trying to stuff them in the closet and close the door fast enough. And if they don't get the door fast enough, it falls back out. Well, that's really what vomiting is doing with your potassium. It doesn't allow it to go in and be absorbed. But the other side of that coin is that our gastric acid has a high electrolyte content. So even if a person's not eating, if we're using NG suction and removing their gastric secretions, we will deplete their potassium that way as well. So it's not just what was in there waiting to be absorbed, it's what's already in the bloodstream being secreted there and then lost. Diarrhea, same thing. We might have made it past the closet door, but it still didn't get into the bloodstream. It didn't go where it needed to go. It went out the back door instead. Diuretics. We're going to talk about diuretics here in a moment, but remember, diuretics produce urine. And where water goes, electrolytes goes, just like Teresa asked a few moments ago. And so when we are making urine, there's a portion of our electrolytes that are lost in that process. Okay? So what are we going to see? Well, we're going to look at or assess their lab. So our best defining characteristic is that serum potassium level. That's our best way to know if somebody has a low potassium. But as you've already seen, sometimes in the nursing home or in the rehab facility, we don't get blood work every single day. So we have to look for signs and symptoms. The two biggest ones I've listed there: generalized muscle weakness. Okay, they just don't have the physical strength to contract those muscles, or a cardiac arrhythmia. Remember, A means without, arrhythmia means without rhythm. Okay, so an irregular heartbeat is an indication of hypokalemia. That irregularity may be fast, it may be slow, it may be intermittent, but it is there. Okay, the heart muscle needs potassium to run like a well-oiled machine. Now, if you look at Appendix F in your drug guide, I think I've mentioned it to you before, there's a glossary of terms. And so if you want to know some of those other signs and symptoms that are not always linked to a low potassium, but can be linked to some other things as well, those are listed for you too in Appendix F. Hypokalemia has much more signs and symptoms than that. So again, when you see an abnormality, look for an answer for it. If you see a reason, so if you see a potential risk, a potential etiology up here, and you're seeing some other strange things going on neuromuscularly for that person, maybe affecting their respiratory rate and depth, then start looking for it, and you'll be surprised. There it is. It is a sign of hypokalemia. It's just not one that Mr. Baird focused on today. Okay? So, simple logic says if their blood potassium is low, our primary nursing action is to increase their potassium level. And so all of our interventions are focused primarily on that. So we can give supplemental potassium in multiple ways. There are various oral forms, so there are tablet forms and liquid forms as well. But some of them are sustained release and some are immediate release. So make sure that what you administer is truly the correct form that the physician has prescribed. They are not interchangeable. You can't supplement without a provider's permission. Increase those potassium-rich foods for those who are still able to eat. Now, obviously, if they have an NG tube, they're MPO, so they can't eat. Okay? Obviously, if they're having vomiting and diarrhea, increasing their food intake's not the answer at that point in time. So when you're looking at these actions, make sure you make them patient appropriate or client appropriate. When you're looking at a test question, use the same approach. Does it fit the character? Does it fit the context of the patient that's in the test stand? All right? So potassium-rich foods, page 1315, there's a little table there, box 52-1, gives you some examples of things that you can encourage and offer to your patients. Okay, I've got a question here in Stillwater. Box 52-1, page 1315. We can give potassium in IV fluids, but it must be diluted and it must be given as a, we call it an IV piggyback. It's an intermittent infusion, or it can be given as an ongoing infusion in what we refer to as primary IV fluid. But never give undiluted potassium as an IV push or as a syringe full of potassium injected into that person's IV. I wish I could switch back to the teacher camera so you could see the emotion that I wish to convey in the story I'm about to tell you. But it's probably been 20 years ago. My wife and I took care of an elderly woman who was in the ICU, in a hospital in Oklahoma City or one of the rural hospitals. I don't really remember now exactly where. She was scheduled to receive a diuretic, furosemide. And at that point in time, the vials that furosemide came in and potassium were similar in size. The nurse inadvertently drew up potassium and gave the same volume of potassium that the patient was supposed to get of the diuretic. Her heart stopped immediately within seconds of her finishing that syringe because she became instantly hyperkalemic. The concentration of that potassium was not diluted in the volume of blood that passed by that IV catheter. So as a result, her heart stopped immediately. Well, she had a terminal illness, but because the healthcare provider is the one who killed her, they had to resuscitate her. Unfortunately, because of hypoxia of the brain, she remained vegetative until she died. And my wife and I took care of her on a vent and feeding tube, and it was a very sad situation because she lived for several months like that when it was simply a nursing error. Okay, so make sure no potassium is given IV push or through a syringe. But you also have to remember, I just said that 80% of our potassium is secreted from our body through our kidneys. So somebody who has poor kidney output, poor urine output, is at risk for becoming hyperkalemic. So we want to make sure if we're going to give potassium supplementation that we are monitoring those serum levels, and we are also monitoring that urine output to make sure they can get rid of any potassium that we give too much of. Okay? When we're giving it as an IV form, maximum is 10 to 20 milliequivalents per hour. Okay, so that's able to be tolerated by the body at that's a safe administration route, or time frame, I'm sorry. But make sure that when you are administering that, as I mentioned a while ago, that you look very carefully at the fine print. Make sure it is the correct dose and make sure it's the correct measurement that the physician actually ordered. Okay? All right. Any questions about hypokalemia? Okay, hyperkalemia is the opposite, obviously, meaning that the serum potassium now is greater than our normal range. So let's see, let's start with still water. So still water, what is our normal range again? 3.5 to 5, what? Milliequivalents per liter, good. It's one of the few lab values I want you to know as a fall fundamental student. So our etiology for this is the same thing. Abnormal intake or abnormal losses. So when we're talking about abnormal intake, that means we gave them too much orally or too much IV route, or their kidneys were unable to get rid of the surplus. So any of those three working hand in hand can push that person into a hyperkalemic state. Now, we don't always know ahead of time in an acute event that the patient may be experiencing a new onset of kidney failure. So we have to be watching for the signs and symptoms of hyperkalemia based on the other things we know about that patient. So recognize that unless a patient has kidney failure, a patient does not become hyperkalemic based on what they eat. So those of you who brought something high in potassium today, as long as your kidney function is good, you could eat as much of that as you wanted, and your body could still get rid of the surplus. But once we add the kidney difficulty into there, then it doesn't even take very much at all, and it could run into a problem for you or for our patients. The other thing that we sometimes forget about is what's the major cation, what's the major cation in the intracellular compartment? What's the major cation in the intracellular compartment? Potassium, that's correct. So if we damage that cell membrane, the potassium no longer has a way to stay there. It's just dumped into the interstitial space and then allowed to diffuse out into the bloodstream. So anybody has a traumatic injury to the tissue, so a crushing type of injury, or a blow, like a blunt trauma type of injury, it releases a lot of potassium out into the bloodstream, out into the interstitial space and into the bloodstream. The same thing happens with a burn, okay? A lot of tissue damage, a lot of potassium that is released, and those people can get into problems very quickly. So once again, we're going to follow their lab values. We're going to monitor those if they're available, otherwise we use those signs and symptoms. Hyperkalemia and hypokalemia have some overlapping signs and symptoms, so we have to use their risk factors to distinguish which one it is. Kind of like the sensory deprivation and sensory overload that Mrs. Martinez talked about. They had some overlapping signs and symptoms, so we had to look at which one the patient was more at risk for to determine what was happening. The same thing is true with low and high potassium. So we have a hyperexcitability, twitching, cramping type of effect, but then we also have paresthesia. I think we're at Enid. Enid, what does paresthesia mean?
Temporary.
Maybe partial paralysis? Well, the reason we're a little slow to answer is because I can't get it all in.
It means something else.
They talked about paralysis, and what else did you guys say?
Like the pin and needles.
Pin and needles.
Yes, it's what happens when your tissues are hypoxic. It's that falling paresthesia. So you feel sensation, but it's a funny kind of awkward feeling, and sometimes it makes it difficult for you to move that part of your extremity. Well, hyperkalemia can generate that same sensation, even though there's plenty of oxygen there. It's the surplus of potassium that's generating that feeling now. Nausea and vomiting. Nausea and vomiting often coincides with hyperkalemia. It's not a cause. Let's see. Stillwater, this is a really challenging one, but why would somebody who has a high blood potassium have nausea and vomiting? What's the connection?
The body's just trying to get it out.
Very good, excellent. The body is just trying to get rid of it. The body knows that its source of potassium comes from the GI tract. So if there's nothing in the stomach and nothing in the bowel, then we're not going to keep taking on more potassium because we're already overloaded already. And so that's exactly what happens. It's a defense mechanism to try to minimize that potassium level growing higher. Excellent. Exhausted muscles. Exhausted muscles simply means that, yes, we were hyperexcitable at one point, but now we've contracted and twitched and cramped and did all this so much, and now we just don't even know what to do. We can't make a good contraction now, and so these people are very weak. So again, we sometimes see the diaphragm being part of that as well, okay? Because it is a skeletal muscle as well. And remember that cardiac muscle is also impacted by it as it is with the low potassium, only this time it's going to suppress its activity. It's going to slow down conduction until it might slow it down till it stops. Being without systole, remember that's when the heart is contracting, so without contraction. In other words, the heart muscle comes to a dead stop. Pardon the pun, that makes the patient dead, okay? No heartbeat means death, right? The only problem is it's hard to get that potassium level down well enough to get their heart started back, okay? So it's a little bit different than somebody who is hypoxic. And so it becomes a very significant challenge. So what are we going to do? Very simply, we're going to decrease the potassium level in the bloodstream. So notice with each of these fluid electrolyte problems, if it's too high, our intervention is to lower it. If it's too low, our intervention is to increase it. Makes it very simple to learn this material. All right, so the drug of choice to lower a person's potassium level is the sodium polystyrene sulfonate. Say that 3 times fast. It is a drug that can be given multiple routes, but it basically pulls potassium from the bloodstream back into the intestinal system so that it can be disposed of in your feces. Remember, that's how it got into the bloodstream, it was absorbed from the intestinal tract. Now we're going to reverse that process by putting this particular drug in the intestinal system and pulling it in reverse. So we're going to take the very physiology that created the problem and reverse the problem, okay, to help them get rid of it. So we can give it rectally as an enema. If they're alert enough to drink it, they can take it. They can tolerate it. Or we can place an NG tube where they don't taste it, but it still goes into their GI tract. We're going to restrict potassium-rich foods until we can resolve whatever their kidney problem or issue is. We're going to restrict those fluids and make sure they don't keep reloading the cannon. We're going to put them on a heart monitor and watch them very carefully to see what their heart is doing so that we can intervene, because there are some emergency things we can do if we see it coming. The physician sometimes will use a diuretic, but sparingly. This one's a little bit harder to process, but why would we use it sparingly? Not the potassium sparing part, that's not what I'm talking about. But what I mean is, why would we use a diuretic sparingly in the context of hyperkalemia? I think I'm at Tonkwall.
And you don't have to worry about the other electrolytes that are being lost.
Okay, it is going to often affect those other electrolytes. That's one good reason. Somebody else help her out.
So they don't become hypervolemic?
Well, I guess there would be a potential if we gave them too much diuretic. There's always that risk. That is true. I didn't hear the last one.
Preventing dehydration?
Very good. If we cause them to lose a bunch of water from the vascular space, and we're going to cause them to lose some potassium, but what if we lose more water than potassium? What does the potassium level look like then? It becomes more concentrated or more elevated because the overall volume of the vascular space is less. So we have to weigh that risk. The provider weighs that risk. Sometimes that's what we have to do because that patient's potassium is greater than 6, and this patient may die very quickly from a cardiac arrest if we don't. But there are some other drugs and some other options you'll learn about probably in adult 2 that are safer probably than using the diuretic option. All right? The diuretic option, however, may be used in the context of somebody who has renal failure to try to jumpstart, I hate to use that word, but that's what providers call it, to try to jumpstart the kidney function back into functioning. Interesting about our body system, especially our kidneys, is if we don't keep adequate fluids flowing through them, then they begin to shut down and don't do their job. It's like, I've been working this hard all my life. I kind of like it not working so hard. And they just stop working, okay? So somebody who has a hypovolemia problem can very quickly end up in renal failure, and then they develop a hyperkalemic problem on top of it. So it's a chicken and the egg. It's just one thing leads to the next. So it's very significant that we pay attention to their fluid status before the electrolytes are all skewed as well. Right? Question?
Fluid bolus. Hopefully.
Very good. The question was, would a fluid bolus help in this context? A fluid bolus will help also initiate urine output, and ideally will take potassium with it. Unfortunately, depending on what's the reason for the potassium being elevated, it may not solve the problem in and of itself. Okay? Very good question, though. Now, Enid, why do I have in parentheses not potassium sparing? What's that statement referring to?
Because those diuretics keep the potassium in.
Some diuretics keep the potassium inside.
They're saying that some diuretics save the potassium in the body?
Very good. And Mrs. Martinez mentioned some of those, and we're going to focus on that in just a moment. One in particular that's commonly used in our area. Okay? All right, so let's shift for just a moment before we come to those medications and
No, I think.
therapy or fluid replacement.
That's his student.
Okay, so I listed 4 purposes there on the slide. That doesn't mean that's the only 4, but those are the big 4. You might call them the final 4, if that helps. First one is to correct loss or losses. So any person who has a low potassium or a low fluid status, we could use IV fluids as a potential to help replenish that. IV fluids to correct the fluid problem, and then potassium mixed in that IV fluid to correct the potassium problem.
Mr. Baird,
Yes,
I think we're hearing an open mic, maybe?
yes, that was ours.
Okay.
That was when my student asked the last question. I opened it and forgot to close it. Thank you. I appreciate you doing that each time, Mrs. Martinez, because I don't look down at that screen unless someone says something.
Yeah, I do the same thing. It's hard to keep track of.
It is hard, I agree. All right, so back to the correcting the loss. So somebody who has a NG suction, so an NG tube dissection, and I told you they're losing GI secretions, and we anticipate that they might develop hypokalemia, so we're going to try to prevent it up front by placing potassium in their IV fluids. We know they need fluid supplementation because they're not taking anything in orally, but we're going to have to add potassium perhaps to offset the losses of what's going through that NG tube. Now, remember, since they're not getting anything through their GI tract, we also use it to meet their need. So their fluid need or their electrolyte need, we're using it based on what that person's personal needs are. So monitoring their INO and their labs help guide the physician in making those decisions. And then the last one is what I mentioned a while ago, preserving renal function. Anybody with sustained hypovolemia, and by sustained, it only takes a few hours, but lack of perfusion to the kidneys damages those kidneys. And then you develop a whole host of other problems, 2 of which we've talked about, hypervolemia or hypovolemia, depending on what your kidneys choose to do, and then the hyperkalemia as well. So when we talk about IV replacement therapy, there are 3 broad categories of solutions. The first one is what we refer to as isotonic. Iso meaning the same tonicity of the fluid. So remember we used the word osmolality to refer to the amount of electrolytes that a person had in their bloodstream. And I told you that that's one of the ways we can tell what their electrolyte balance is as a whole, not individual electrolytes, but as a group. So isotonic fluids have the same osmolality as the human body's plasma does, meaning that when we infuse them, they disperse evenly both within the vascular space, as well as the interstitial space, as well as the intracellular space. ICF meaning intracellular, extracellular meaning vascular and interstitial. Remember, those are 2 subcomponents of ECF. So isotonics is a way to replenish somebody's fluids when they have been hypovolemic long enough that the body's already pulled fluids out of the interstitial space. These are the people who are either have been depleted for a period of time, or they've lost such a large amount right up front, right now, that if we don't fix it, they're going to have that fluid shift problem. Okay? Hypotonic has a lower osmolality than plasma, and it can cause a fluid shift between the different compartments. What that means is, when we start putting that into the vascular space, it's going to dilute some things in there, and as a result, the fluid in the vascular space may shift out into the interstitial spaces. These fluids are ideal for somebody who has been dehydrated for a long enough time that you're seeing tinting of the skin. So when you're checking their skin turgor, their interstitial space is so depleted, we want to rehydrate that before the tissue begins to die. And so a hypotonic fluid is often what's prescribed for that. I mentioned there intravascular to intracellular, meaning that even though it goes from intravascular to interstitial, it's going to go from interstitial into the cells themselves. So again, it's a two-step process, but a hypotonic fluid is the fluid that can do that. Hypertonic is the opposite. It has a higher osmolality than plasma, meaning it's going to pull stuff into the vascular space. It's like the blood transfusion that we talked about the other day.